Hi, my name is Charles Cole. I'm an orthopedic surgeon and I work at Sun Orthopedics of Evangelical Hospital. About the last 15 years, I have had a concentration in arthritic knees, particularly the area of knee replacements. So that is basically a large part of my practice is taking care of arthritic or degenerative knees. So if you think you have an arthritic knee or you think you have a problem with your knee that might be something arthritic, what we recommend is people come into the office and we do an initial evaluation based on your age, how long you've had the pain, things like that. But more so, what's most important is we get an x-ray. And in this day and age where you can get all kind of testing such as an MRI and other pretty specialized tests, really a standing x-ray of your knee tells us a lot. In fact, tells us almost everything we need to know as far as the extent of the arthritic change in a knee. And so typically people will come in and we will see if they've had x-rays, and if not, we will do things like that, get standing up x-rays and examine the knee and determine if it's an arthritic problem with the knee or if it's something otherwise, a ligament injury, a cartilage injury. But those tend to be more common in younger people, so the patients I see tend to be older and tend to have more arthritic problems. But there sometimes is a crossover with that, but I think that in general, most people have an idea if they're dealing with something acute or something chronic like arthritis. If we determine that a patient does have arthritis in their knee based on studies and an examination, a big thing that matters is to what level is the arthritis. So if it's moderate or the beginning stages or moderate, as I said, then we certainly pursue a conservative course. And actually even people that have rather advanced arthritis can actually have conservative measures done for some time and be able to tolerate their arthritic knee. I'll just keep it at the arthritic knee area. And so we will start with things like anti-inflammatory pills and exercise and bracing, things along those lines. There's injections that we use in the knee that can really, and all those things combined, really can make a difference in prolonging needing something major such as surgery. When we determine whether or not someone needs surgery, it's based on how they've responded to the conservative measures and really how far along their arthritis is on the objective side. That would be how bad is the x-ray, how bad does the knee examine, and are you responding to the conservative measures. Deciding on whether someone is a candidate for a knee replacement, we evaluate both how they feel, the x-rays and testing, and as well as examination. So really the number one reason to have a knee replacement done is pain that is limiting function. Pain that is unremitting or is not being relieved with the measures we're using. And the difficulty comes in is there are a lot of people that have quite a bit of pain in the knee, yet they're not really a candidate for a knee replacement because they don't have enough wear in their knee. So we kind of have to have both. We have to have enough objective evidence that the knee is bad enough, and enough subjective evidence or the patient saying, hey, it really is unbearable, and having failed all the treatment, then you become a candidate for surgery. The pain relief is what we really want to achieve, and if you ask people about their knee replacement, how they did, and then once it's all over, most people will tell you that the most satisfying thing is that the pain relief is really outstanding. In the vast majority of patients, the pain, you have little or no pain once the recovery is complete, and that's really the best benefit of the surgery. The pain relief is remarkable. It really is. When you are a good candidate for a knee replacement, and if you have a good result, most people do very, very well.